This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
Welcome to the University of California Davis Health System. Since 1973, continuing medical education, CME, has been an integral part of the educational mission of the UC Davis School of Medicine and Medical Center. The Center for Health and Technology, CHT, increases access to health education and promotes interaction between patients, physicians, and other healthcare professionals through the use of telecommunications and computer technology.
I am Dr. Lin Zhang, the Associate Professor in Neurology, with a joint appointment to the Department of Neurological Surgery. I co-direct with Dr. Chalet the Center for Neuromodulation and Neurorestoration. Today, Dr. Chalet and I are presenting DBS, Deep Brain Stimulation, to you, and the lecture will be composed of two parts. Part one, I will present the medical application and patient selection for DBS surgery. In part two, Dr. Chalet will cover surgical perspective on DBS. I do not have any relevant financial relationships to disclose. In this part of the lecture, we will discuss in detail of the approved indications and patient selection process for DBS surgery, and we will also touch on the future indications for DBS surgery and the proposed mechanism of DBS. The last two areas will be discussed in much more detail in Dr. Chalet's presentation following. Electric stimulation has been used since ancient times to treat a variety of neurological disorders and to manipulate the nervous system. Various surgical techniques such as resection, lesioning, and stimulation have been used to treat variety of movement disorders for the past 50 to 75 years. Irving Cooper in 1953 first described his experiment using ligation of the anterior choroidal artery to treat Parkinson disease. And in his earlier report, he had 6 patients ligated, or was 6 patients had 8 ligations. Their Parkinsonian symptoms such as rest tremor, rigidity, and contralateral cogwheeling resolved following the ligation of anterior choroidal artery. Subsequently, there was an explosion in the stereotactic functional neurosurgery in the late 1950s. Pilototomy and thylamotomy became the commonplace in neurosurgical management of Parkinson's disease and rest tremor and essential tremor during those times. In 1968, however, the functional neurosurgery as a form of management of movement disorders, Parkinson's disease, and essential tremor and dystonia ground to a halt with the introduction of levodopa therapy. Late 1980s and early 1990s, the limitation of dopaminergic therapy was widely recognized, leading to a resurgence of new surgical techniques directed at basal ganglia targets. The high-frequency stimulation, HFS, that was believed to be the mechanism of DBS surgery, was introduced treating advanced Parkinson's disease in 1993. The commonly approved indications based on the FDA published approval are listed on the slide. Essential tremor was approved by FDA in 1997 for the application of DBS surgery. Parkinson's disease in 2002, dystonia, and obsessive compulsive disorder have been approved since 2003 and 2009, respectively. Please also note that the last two indications are under HDE code. HDE stands for Humanitarian Device Exemption. Now we'll cover the overview of DBS surgery. DBS offers hope to severely, in general, impaired patients when their symptoms are intractable, despite the optimal medical management and other available therapies. DBS overall carries over 2 decades of record of safety, and there have been over 125,000 DBS implanted worldwide as of 2012. There have been over 3,500 published articles on DBS. With proper patient selection, the improvement with DBS surgery have been seen with standard rating scales and measurements of disease, quality of life measures, comorbid conditions, medication intake, and overall chronic care costs. The key to the success of DBS surgery lies in patient selection. The goal in patient selection is to identify the ideal patients where their individual benefit outweighs the risk of surgery. Use PD as an example. These patients would have to be at advanced stage with frequent and prominent motor complications. In the case of tremor, these patients would have their symptoms interfering with their activities of daily living, and their medications would have to be ineffective and/or causing intolerable side effects. As to dystonia, they have to be at least 7 years of age, and they have to have the diagnosis of chronic primary dystonia, and their medication management would have to be unsuccessful on clinical measurements. DBS as an intervention relies on the response or patient's response to levodopa. Here we utilize Parkinson's disease as an example to illustrate the proper steps for patient selection to determine their eligibility for DBS surgery. As we mentioned earlier, the response to levodopa tends to serve as the best prognostic indicator for DBS suitability. Neuropsychological evaluation is also a crucial part of the pre-DBS evaluation to determine patients' eligibility for surgery, because the neuropsychological evaluation will help to identify comorbid conditions such as depression, psychosis, and full-blown dementia. The age is also an important consideration. FDA recommends age of 80 to be the upper limit for DBS surgery. A full medical assessment gets carried out during the pre-DBS evaluation process to identify the diagnosis of medical conditions, to also evaluate patients for proper medical management to get them ready for DBS surgery. The discussion of long-term and short-term effects of DBS also is carried out in this process, and the education regarding environmental concerns with implantable devices such as DBS is also an important part of this process. Next, we'll go through step-by-step of patient selection process to determine their eligibility for DBS. First, their medication response gets determined. In order to determine their medication response, patient with Parkinson's disease, as example, would come in early in the morning to be off of their medications the night before. Therefore, they are off of their medications for at least 12 hours in duration to be tested at their, quote, off stage, unquote. During this test, patients get clinically rated with a standardized rating scale according to standardized testing protocol for their off-stage motor performances. Then patients are sent home with resumption of their medications and return either on the same day or the next day to be tested again for their, quote, on stage, end quote. The comparison between the on state and off state of their motor performances help to determine their eligibility for DBS surgery, and such difference between the two stages have been very well correlated with the promising and favorable outcome of their DBS surgery. Neuropsychological assessment is also a crucial part of their of the selection process to determine their eligibility, and that's get carried out with our designated neuropsychologist and her staff and fellows. In this process, patients' full neuropsychological performance gets assessed, and the cognitive integrity of the patient gets determined and reported. Neurosurgical consultation with Dr. Chalet and his staff also is a crucial part of the patient selection process. During that meeting, patients will be fully disclosed, and the surgical benefit and risk are fully revealed with the patient and their caregiver and family members. A brain MRI is also performed according to a standardized testing protocol to exclude any anatomical abnormalities of their brains, and also to help with the determination of the target of their DBS surgery, for their DBS surgery. At the end of the pre-DBS evaluation, the case conference and team meeting is conducted to reveal each component of the evaluation of the patient's performance based on their clinical evaluation and medical history. Finally, outcome of the case conference is outlined and shared with patient and their family members. As we alluded earlier, target sites are apparently a very important part of the DBS surgery. Now, this will be discussed even further in Dr. Chalet's presentation. Here, I wanted to bring to your attention to the specific areas of the brain as illustrated on the slide that are pertinent to the specific diseases. VIM, for example, is a target treating essential tremor. STN and GPI are well-defined targets treating Parkinson's disease and dystonia. VIM stands for ventralis intermedius nucleus of the thalamus. GPI, posterior ventral portion of the internal segment of the globus pallidus. STN stands for subthalamic nucleus. Going from the pre-DBS evaluations to the post-DBS electrode-stimulator connection, we apparently skipped the surgical process, the most crucial part of the DBS procedure. The reason is Dr. Chalet will cover in much more detail, step by step, of the surgical process. Now on this slide, electrode-stimulator connection is shown. As we go through the different areas of stimulation parameters we operate, post-op, as you see, the physician is holding a physician programmer, and to the right upper corner of the slide, you see the patient programmer showing in black color with two little dots on top of the box for the patient's adjustment of his or her own stimulator. Now, this slide illustrates several things. One is that the electrode-stimulator connection that is established during the surgery is the system that we're taking advantage of. Now, such system provides the most flexible adjustability for the physicians and patients to use. The parameters that are electric parameters that are generated by the generator, which is shown in white, a square-shaped white little box, a metal box on top of the slide on the to the right corner, is implanted under the clavicle on the usually right side of the chest under the skin. Now that little white box gets connected with the stimulator inside patient's brain to the target relevant to the patient's disease condition. And this system provides the electric stimulation to the stimulator via the generator. The parameters that are controlled by the programmer and also subsequently by the stimulator are: number one, pulse width; two, rate, which is a frequency; three, amplitude, which is a voltage. We adjust the voltage most frequently, and patients is also given some flexibility to adjust the certain parameters at home. Therefore, their daily activities are or can coincide with their stimulation. Patients come back to our office according to the set-aside frequency of visits to have their parameters checked and to have their stimulation checked and parameters adjusted. Initially, such visits are more frequent, say every 2 to 3 weeks, to come in right after the surgery. And then over time, the frequency of the visits decreases accordingly. The field of functional neurosurgery has witnessed renaissance over the past 20 years. DBS, with its flexibility of reversibility and adjustability, has gained significant popularity and emerged as the standard of care neurosurgically, managing a variety of movement disorders and other disorders. The mechanism of DBS has been very well studied. However, the exact mechanism underlying the benefit effects of DBS, which is apparently very well known, are still unknown. Dr. Chalet will go into more detail discussing the mechanism of DBS and also the different hypotheses here. I would like to mention that the logistic fallacy still exists, and many hypotheses exist regarding the mechanisms of DBS underlying high-frequency stimulation, which is what DBS is believed to deliver. Brain circuits that outlines the basal ganglia is illustrated here as relevant brain structures involved in the basal ganglia circuitry, and this is apparently very complex diagrams. Dr. Chalet will try to simplify them for you in his presentation following. Using Parkinson's disease as example, as you can see, diagram A and B show significant difference in terms of output systems from the cortices and also the input systems and feedback mechanisms going back to the cortices. And the end result under normal condition is a very well adjusted and very well timed system that adjusts the motor function, especially as a fine motor function, minute to minute. However, in the case of Parkinson's disease, such fine motor adjustment is disrupted. As a result, and patient will develop symptoms that are the consequence to such disruption of the systems. Now, again, the systemic adjustment is going to be further discussed in Dr. Chalet's presentation following. I would like to end the discussion on mechanism of DBS by stating that the prevailing hypotheses postulate the following. DBS provides the inhibition at the neuronal level, and is also believed to provide activation at the axonal levels. DBS leads to the interruption of the excessive and abnormally patterned neuronal activities in the targets, as we mentioned earlier, STN and the GPI, and the interconnection or interconnected component of the basal ganglia network becomes readjusted through the DBS stimulations. Comparing to, or in contrast to the lesion surgery, DBS provides the following advantages. It avoids the it avoids the adverse side effects associated with lesioning procedures. DBS does not require deliberate destructions of the brain regions, and the effects of the stimulation that the DBS delivers is fully reversible, and then DBS can change the stimulation parameters, as we illustrated earlier, to optimize the clinical benefit. And the beneficial changes of DBS are believed to be long-lasting. Needless to say that, however, DBS does carry certain important disadvantages. The next two slides will reveal these disadvantages and risks associated with DBS surgery. Adverse effects related to surgery include many prominent conditions, such as listed here: intracerebral hemorrhage, subdural hematoma, seizures, as example. DBS introduces hardware into the brain and patient's body. Therefore, hardware-related failures can occur, such as lead extension fracture, lead migration, short or open circuits, and malfunction of the implantable pulse generator, and even infection. These conditions have been reported in the literature with the DBS surgery. Adverse effects related to electrical stimulation can also occur. Electrical current could spread into adjacent structures, leading to tonic muscle contraction, dysarthria, which is a slurred speech, paresthesia, which is abnormal sensation, and worsening of their akinesia, which is the abnormal sensation, are different types of abnormal sensation that tends to occur with Parkinson's. Additional disadvantages and risks associated with DBS is listed here. Post-op adverse effects are relatively common, including weight gain, dyskinesia, which is abnormal involuntary movements of the body, axial symptoms such as truncal instability and gait disorders, eyelid and ocular disturbances such as ocular apraxia, behavioral and cognitive problems can also occur, muscle contractions, paresthesias, and speech dysfunction may occur. Costs of surgery are also of concern. DBS cannot use sham surgeries as controls, and the long-term complications associated with DBS include infection, erosion, pain and discomfort, sudden loss of effect, tolerance, and development of full-blown dementia. The next segment of the presentation we will use as video that is capturing a patient who had years ago in an outside facility VIM DBS implanted, treating his unique tremor condition. Now, his tremor is a part of diagnosis of fragile lax associated tremor ataxia syndrome, FASTAS. Now, this case has been published by our group as one of the 3 cases in the case series, illustrating the benefit of DBS surgery treating FASTAS patients as one of the first such reports in the literature. Now patient's stimulator has been turned off, and he's been asked to stretch his arms out in front of him, and now he's being asked to do what is called finger-to-nose test. He's asked to point his finger to that pencil. Now he's asked to draw a circle within the spiral. And now he's asked to pour water from one cup to the next. Try to make sure not spilling. And now he's asked to walk on a straight line. As you can see, he has significant truncal ataxia. Now his stimulator has been turned back on. He's asked to repeat a sentence. He's asked to perform the same test as before, to have his arms stretched out, to point to the pencil and back to his nose and back to the pencil. He's asked to draw the spiral. Lastly, he's asked to pour from one glass or one cup to the next without spilling. As you can appreciate the significant benefit from such stimulation, and he's asked finally to walk on that straight line. The future of DBS surgery will be further discussed by Dr. Chalet in his following presentation. Here I would like to bring your attention to these disease categories that currently under study in various institutions, including government agency and pharmaceutical industry. Obsessive compulsive disorder is being studied by NIMH, National Institute of Mental Health. Depression is currently studied and in the final analysis phase in the University of Emory. Pain syndrome is currently studied in Cleveland Clinic. Morbid obesity is being researched at the Ohio State University, and epilepsy is expected to be revealed by the FDA for the official approval, which is apparently at this time still pending. At this point, I'd like to introduce you to my dear colleague, Dr. Chalet, who will pick up the second half of the presentation under the topic of demystifying deep brain stimulation, surgical perspective. Thank you.
Okay, well, thank you, Dr. Zhang, for that great introduction into deep brain stimulation. And what I'd like to do now for the second half of this talk is go over the surgical technique and how we do deep brain stimulation surgery, why we do this to begin with, and what the outcomes are in general, and how we see this field advancing in the future. I have no relevant financial disclosures to share. And what I'd like to do is start with the history of deep brain stimulation neurosurgery. How did we get to this idea of targeting the basal ganglia in the brain to help patients with movement disorders? Now, this goes back quite a ways, and Irving Cooper is one of the early neurosurgeons that opened the doors to this field of functional neurosurgery. Dr. Cooper was a very interesting person. He was the son of a salesman, born in Atlantic City, New Jersey. Worked his way through school and then went on to join the faculty at New York University, then New York Medical College. And he's really regarded as one of the pioneers in functional neurosurgery. And the way that Dr. Cooper became interested in the basal ganglia is he was performing a surgery on a patient that had a tremor and doing an operation that we don't do anymore called a pedunculotomy. And during that operation, there was an accidental injury to one of the blood vessels on the base of the brain. Now, that blood vessel was the anterior choroidal artery, and the patient survived the surgery, and when he woke up, his tremor disappeared. And what Dr. Cooper discovered is by damaging the anterior choroidal artery, he had actually created a very small lesion in part of the basal ganglia. And this was one of the first times that a neurosurgeon discovered that perhaps if we target the basal ganglia, we can improve movement. So what exactly do the basal ganglia do? Well, they have a very interesting connection with the rest of the brain. We know that the top of the brain is important for regulating movement, but the basal ganglia helps to scale movement and to focus movement. And the scaling of movement means altering the amplitude of movement of our arms and legs and the velocity, how quickly we move. And the focusing of movement has to do with selecting the appropriate muscles for the appropriate type of movement, and to be sure that we shut off muscles that might interfere with that movement. And there are many ways that this happens. It's a very complex circuit between the basal ganglia and the cortex of the brain. And we know that our patients in Parkinson's disease, with essential tremor, with dystonia, and with other movement disorders seem to have some problem with the way the basal ganglia is doing its job. Now, we refer to something called the rate model, and the rate model is shown here in this diagram. It shows the connections between the different areas of the basal ganglia, which are illustrated on the right side with acronyms. And a couple of areas in particular that we want to highlight is the STN, or the subthalamic nucleus, and the GPI, or the globus pallidus internus. On this next slide, you can see the rate model, and the rate model helps us to explain why we think patients with different movement disorders develop the symptoms that they do and what parts of the circuit are not working properly. As you can see here on the left side of the panel, this is how we envision hypokinetic disorders to develop in the brain. We think that hypokinetic disorders, such as Parkinson's disease, are due to an overactivity in the subthalamic nucleus and an overactivity in the globus pallidus internus. And this happens because of a loss of dopamine cells. The dopamine cells normally will activate the direct pathway and inhibit the indirect pathway. And when our patients lose dopamine cells, we see these pathways behaving in an abnormal way, and we see the STN and the GPI being overactive. On the other hand, on the right side of the screen, you can see the model for hyperkinetic disorders, things such as dystonia or hemibolismus, or some patients with Huntington's disease, where there's increased activity. And hyperkinetic disorders seem to have the opposite phenomenon. We see underactivity in areas such as the globus pallidus internus. So this rate model, this circuitry, if you will, that shows us how the basal ganglia and the cortex of the brain are working together, has been used to help us target areas in the brain for functional neurosurgery. And this slide illustrates that very well for Parkinson's disease. As you know, Parkinson's disease is one of the most common indications for deep brain stimulation surgery. And because patients with Parkinson's disease are losing dopamine input to the striatum, the direct pathway is underactive and the indirect pathway is overactive. And the net effect is that the STN, the subthalamic nucleus, and the GPI, the globus pallidus internus, is overactive. These are two deep brain areas, and these are two targets that are part of the basal ganglia. And these are areas that, when they're overactive, we think they cause the symptoms of Parkinson's disease. And this is the important rationale that we use for performing functional neurosurgery. Now, what is the goal with deep brain stimulation surgery for Parkinson's disease? Well, we want to make sure we do it in the right patients that have the proper indications. We want to be sure we're not doing it in patients that are going to suffer from the operation. And this slide summarizes some of the indications and contraindications, and the previous speaker went into this in more detail. But just to again remind ourselves, the indications for deep brain stimulation for Parkinson's disease is a clear diagnosis of idiopathic Parkinson's disease, not a Parkinson's disease that's due to something else, but something that has occurred for no good explained reason. We like to make sure that our patients are still having a good motor response to dopamine, because we think that the response to dopamine medication predicts how well they're going to respond to deep brain stimulation. patients that are experiencing a lot of motor fluctuations and dyskinesias from their medications. In other words, patients that are not experiencing a lot of good, what we call on time, but actually fluctuating between a lot of on and off time, are patients that would probably benefit from having a stimulator implanted. And we want to make sure that when patients are on, they're able to walk and be independent. Because if their best on state is not a very high quality state to be in, then deep brain stimulation may not be as effective. There are some contraindications. Patients that have dementia are not good candidates for this treatment. Some folks believe that patients that are very old, above 80 years of age, may not be the best candidates, although we never rule out anyone based on age alone. It's always based on a thorough assessment of all the comorbidities that may be present. Again, patients that have a poor function when they're on are not going to do well with DBS. And the physician-patient relationship is very important with this treatment because, as the previous speaker showed, there are a lot of visits and a lot of programming subtleties that have to go with deep brain stimulation treatment, and it's very important that patients and physicians are able to work closely and work together to make sure that DBS is providing the maximum therapeutic benefit that it can. There is a discussion that's usually held about whether both sides of the brain need to be treated at once. In most cases, especially in Parkinson's, both sides of the brain are dysfunctional and do need to be treated with deep brain stimulation. Now, what are the goals of the surgery? Well, the first and most important goal is to do no harm. That's true for everything we do in medicine. It's particularly true for this surgery because it is an elective operation. It's not an operation that is a matter of life and death. It's a matter of improving quality of life. So patients that decide that this is the right operation for them certainly need to be feel safe that this is an operation that is being done with the lowest risk possible. And in order to do a safe operation, we need to be able to implant the electrode with a high degree of accuracy. So as you can see on this slide, location, location, location is so critical for safe deep brain stimulation surgery. And in order to get accurate implantation, we do this surgery typically in an awake state. Our patients come to the operating room and are woken up during surgery. And there are many layers of targeting that I'm going to go into with the slides that follow to show you how we do this targeting indirectly, directly, and then physiologically to make sure that our electrode ends up in the exact right location. And once a deep brain stimulation system is in, then the goal is to be able to return to the neurologist a patient that has an implant in that is adjustable, that is reversible, that if one day could even be turned off, turned up. And that adjustability and flexibility in the system is a huge advantage of DBS. So what I want to do over the next few slides is walk you through the process that we go through as a team when we're preparing a patient for surgery and how we achieve the targeting that we need to achieve. Indirect targeting refers to the targeting that is done based on the initial MRI scan and where we expect things to be in the brain normally. Indirect targeting starts with a very high-quality MRI scan. This is an MRI scan that does not miss any slices in the brain, so it captures the entire three-dimensional anatomy of the brain. And we go through the scan and we identify certain structures within the brain, the anterior commissure, the posterior commissure, and some midline structures. These are structures that are constant in everyone's brain. Once we identify where these structures are located, our software system will identify a point in space called the mid-commissural point. That point is at 0, 0, 0 in XYZ space. That gives us a three-dimensional graph, and using that coordinate system, we can go to any location in the brain. That's the first step, and that's indirect targeting. After indirect targeting, we then move to a targeting system that allows us to pick the target we want based on XYZ coordinates of locations where we typically find the nuclei we're interested in. So for example, if we're targeting the subthalamic nucleus, the STN, which is a very popular target for Parkinson's disease, we know that it is typically located 12 millimeters lateral to the midline. We know that it's typically located 3 or 4 millimeters behind the 0, 0, 0 point, and we know that it's located 4 millimeters below that 0, 0 point. And so we go to that point on our software program, that XYZ coordinate, and that's our indirect targeting. And then we do what we call as direct targeting. We actually look at that point on the patient's MRI and determine if their STN is exactly at that location. Many times it is, but in some cases we have to make a small adjustment and move the target either medial, lateral, forwards, or backwards, sometimes up or down. in order to target the exact correct part of the STN. These are very small targets. The STN is typically less than a centimeter in size. It's usually about 7 millimeters at most. And even being off 1 or 2 millimeters can have a lot of problems with our DBS system, and our patient may not get the benefits they need. So accurate targeting and moving from indirect to direct targeting to be sure that the area that we see on our MRI is the area we want to target is very, very important. The indirect and direct targeting leads us to selecting a safe entry point and a safe trajectory. And this is also done before surgery. We try to select an entry point that goes through an area of the brain that is a silent area. We make sure to avoid any blood vessels or any other gyrations in the brain where we know there's a higher risk of causing bruising or bleeding. And we try to pick a trajectory that will get us down to the target, the deep brain target in the brain, that will avoid going through any sulci in the brain, any ventricles, and avoid where we know blood vessels are typically located. This is a very important step, and this takes a lot of time, and it's something that's done by the surgical team before the patient even comes in for surgery, to be sure that on the day of the operation we've selected a safe entry, a safe trajectory, and the correct target. Now, what is the day of surgery like? Well, this slide illustrates for you the typical day of surgery, and patients usually will come in early, about 6 o'clock in the morning, to our preoperative area. They'll meet with the anesthesia team. At about 6:30 to 6:45, the surgical team will show up, and the first thing that we do is we place a frame on the patient's head. This is a ring that looks like a halo, and it's held in position with 4 pins that go into the skull. Local anesthetic is used, and patients typically don't feel any pain during this process. Once the ring is on the head, then we take the patient down to the CT scanner. We do another scan of the brain and head, and we take that scan with the ring on and we merge it to the MRI plan that we made. And this is a very important step because this allows us to go to the operating room, use the plan that we made ahead of time, and use our targeting system to reproduce the trajectory, the entry, and the targeting point that we had selected before surgery. This is done with a neuronavigation suite that we use, and this is a computer-based program that's in the operating room. After the CAT scan, the patient's brought to the operating room, placed in a very comfortable lawn chair type of position with the arms and legs very well padded and with the head secured to the table so that they can relax their head and neck. And our goal is by 7:30 in the morning to start surgery. The patient is put off to sleep, and as you can see here, a CT scan machine is brought in around the patient's head. This is the yellow donut you see on the left panel. And the patient's head is prepped and draped, and while they're asleep, the incisions are made, the openings in the bone are made, and the electrodes are passed to about 15 millimeters above target. The first electrode we pass is a microelectrode. It's about the size of a hair, and it's an electrode that will park just above the target before we wake up our patient. Once the electrode's in position, the patient wakes up in the middle of surgery. They typically feel no pain because all of the areas have been numbed up. And then we begin what we call microelectrode recordings. We record activity from the brain with the patient awake to make sure that we are in the exact right location. Now, this next slide shows you some example recordings of a patient having subthalamic nucleus recording and stimulation done. And as you can see, when the electrode passes down to the target in the STN, we expect it to go through certain areas of the brain that have a characteristic firing pattern. And that helps us to confirm that we're in the right location. When we get to the STN, we then will record from that area while we move the patient's arms and legs and ask them to do various tasks. These are simple tasks, but they're tasks that confirm for us that we're in the part of the STN that's responsible for movement, and therefore the area that's responsible for their symptoms, be it tremor, slowness, or tightness. We have a goal of being able to identify the right area of the STN and traversing a long enough segment that we know it'll be good for chronic stimulation. We know that the STN has an organization within it where the leg is located in one area and the arm is located in another area, and we confirm all of that during this recording period. The awake recording period on each side usually takes about 30 to 45 minutes. Once we've selected the right target to implant, then the actual DBS electrode is put in. This is a larger electrode. It's about the size of a spaghetti noodle, and it's passed into the subthalamic nucleus in the area that we were recording from. And then we do something very exciting. We actually turn it on for the first time. Our patient's awake, and our neurology colleagues are there turning the stimulator on. And what we'll typically see in the operating room is we'll see the tremors disappear, we'll see the tightness and the slowness resolve, and we'll see a dramatic improvement. And that confirms for us that we're in the right location. We also look for side effects, which we expect side effects when the stimulation is very high. Not at a level we would use chronically, but at a level that confirms for us the nearby structures that we expect to see. And once we've completed with what we call test stimulation, then the awake portion of the surgery is done. Our patient is put back off to sleep, the electrode is secured to the scalp, the wounds are washed out and then closed. In an operation that's bilateral, we would move to the other side before finishing the surgery, repeating all the same steps. This slide summarizes some of the test stimulation results that we expect to see based on the target that we're in. And as you can see, when we're in the subthalamic nucleus, if we're a little too lateral or a little too medial or a little too posterior or a little too anterior, we see specific types of side effects. And this is very important, and seeing this in the operating room helps us to make adjustments before we place the electrode in its final position. So it gives us the ability to make sure that the electrode that the patient leaves the operating room with is going to be in the best position possible. Now, after the electrode's implanted, we like to do imaging to confirm the location visually as well. And we do this using various techniques. We do MRI scan usually the evening of surgery or the day after. We also can do CAT scans within the operating room, and this is a technique that we've developed with our colleagues at UC San Francisco, and it's a technique that we do routinely on all of our surgeries here. And by using this technique, we're able to immediately confirm that the electrode's in the right location. Most patients will stay the night in the hospital. Most patients are ready to go home by the next day. Typically, the pain after surgery is very minimal, just a little bit of soreness in the areas of the incision. Now, after the first surgery, there's a second stage where the patients come back a week and a half later for implantation of the battery. The actual battery goes in a pocket under the collarbone in the chest, and there's a wire that is tunneled up the neck under the skin and connected to the leads that were placed in the first surgery. After that second stage is done, and that's done as an outpatient surgery, then the patient will come back later, typically within a couple of weeks, to start programming. And as you saw in the previous talk, the programming can take quite a while, and it can be a very exciting time and a very interesting time as our patients are able to start cutting down on their medications, start going up on their stimulation, and hopefully achieve benefits that they haven't seen with medication alone. Now, this slide summarizes some of the outcomes that we typically see with deep brain stimulation. In patients with Parkinson's disease, where we're targeting the subthalamic nucleus or the GPI, the globus pallidus internus, we typically see improvements in the UPDRS score, which is a scoring of the severity of their Parkinson's disease, ranging in the 30 to 35% range. Sometimes this can be a lot higher depending on our patient's specific deficits and how well chosen they are for surgery. The activities of daily living tend to improve at least 40%. And on average, patients that have an electrode implanted in their subthalamic nucleus, medication doses are reduced by about 50%. And that can be a huge improvement for patients that are experiencing a lot of side effects from their medicines. Patients that have essential tremor, they will have a DBS electrode that's targeted in the VIM of the thalamus. This is a slightly different target. And patients with essential tremor can see an improvement of 80% on average in their tremor severity. Their handwriting can improve by up to 70%, so the improvement with tremor can be quite dramatic. And dystonia is the third movement disorder indication for deep brain stimulation. With dystonia, we target the GPI, the globus pallidus internus, and we tend to see improvements ranging anywhere from 40 to 70% in primary dystonia, and somewhat lower in the teens to the 30% range in secondary dystonia. Now, it's important to think about the complications of deep brain stimulation surgery, because we went over the advantages and what we expect to see, but there certainly are disadvantages to having an invasive operation. In general, the complications of DBS surgery are low, but they're not zero. The highest risk complication is infection, and infections tend to occur in about 5 to 10% of cases. Most infections occur in the deep brain stimulator battery, which is located in the chest. And if those infections are caught early, About 2/3 of the time, removing the battery and treating with antibiotics is all that needs to be done, and the system can then be reimplanted a few months later. In patients that develop an infection that begins to go up the wire, we will take everything out quickly because we do not want to allow that infection to get to the brain. So infections can be caught early and managed well, but sometimes they will require removal of the entire system. We take a lot of precautions to reduce our infection rates, but we all know that infections are a problem with deep brain stimulation surgery, and they're a challenge that is improving but is still there. The second most common risk that we worry about with deep brain stimulation surgery is causing bruising or bleeding in the brain. Now, this happens in about 1 to 2% of cases. Most of them cause no symptoms. We just see a little bit of bruising or a little bit of blood surrounding the electrode in the brain tissue itself, but the body will resorb that and our patients heal up just fine. However, there is a small chance, less than 1%, of having bleeding or bruising in the brain that can result in a stroke. Although the risk is low, it's a very, very important risk to discuss with our patients because this is a risk that our patients need to understand and be okay with, and they have to feel that that low risk is justified by the potential benefits of having a deep brain stimulator electrode placed. Now, what I want to do before we conclude is just briefly talk about the future of DBS surgery and where we think we're going with this. As I alluded to earlier, intraoperative imaging is a very exciting new development in deep brain stimulation surgery, and it's something that we're doing routinely here at our center now. We feel that doing an imaging study in the operating room with a CT scanner is very advantageous, and it has allowed us to identify a lead placement, lead location, and be sure that we've implanted the lead exactly where we want it to be. There also is a role for MRI as well, and there are centers that are starting to do deep brain stimulation surgery under MRI guidance. This is a different surgery because the patient is not awake, they're asleep, so you're not able to do the microelectrode recordings, you're not able to confirm that the stimulation actually has the benefits you think it does. However, it seems that using MRI may be as effective as doing an awake surgery, and so we're very excited about the potential of MRI-guided surgery in the future of DBS. And finally, what I want to talk about are maybe new targets for deep brain stimulation surgery. What we've talked about today are the subthalamic nucleus, the globus pallidus, and the VIM of the thalamus, and those are the most commonly used targets for movement disorders. However, we may be able to give our patients even more relief if we have a different strategy with our targets. And there are many people that are looking at different targets, looking at perhaps putting in multiple electrodes within a target like the globus pallidus to treat dystonia, which is more difficult to manage with DBS than Parkinson's and essential tremor. We're also looking at the subthalamic nucleus as perhaps a good target for dystonia as well as Parkinson's. And we're starting to look at different stimulation strategies in our patient. Perhaps a lower amplitude stimulation or lower frequency stimulation may be more effective in certain patients that aren't getting a lot of benefit from their deep brain stimulator. In Parkinson's disease, we know that some symptoms of Parkinson's disease do not respond well to DBS. The symptoms that respond well to dopamine generally respond well to DBS, but symptoms such as gait freezing or difficulty with balance are symptoms that do not respond well to stimulation of the STN or the GPI. And so there's interest in other brain targets that may perhaps be as effective or more effective in treating some of these symptoms. So that concludes our review of the surgical aspects of deep brain stimulation surgery. As you can see, this is a very exciting and innovative, minimally invasive, functional neurosurgical technique that we can offer our patients with movement disorders. And we're all very excited about the future of deep brain stimulation to improve movement disorders and other neurological conditions. Thank you.